Welcome to Committing to Equity, How to Drive Change in Overdose Prevention, Treatment, and Harm Reduction. My name is Merlene Tucker, and I'll be running today's web forum along with my colleague, Jeff Bornstein. Today's web forum is sponsored by the National Overdose Prevention Network, a program of PHI Center for Health, Leadership, and Impact, and produced by Dialogue for Health. Let's meet the moderator of today's event, Veronica Johnson. Veronica is a program coordinator for PHI Center for Health, Leadership, and Impact. Her work focuses on supporting the California Overdose Prevention Network through coordinating operations for the statewide learning network and accelerator cohort program. Welcome, Veronica.
Thanks so much, Marlene. Hello, everyone, and welcome to today's webinar. If we can go to the next slide, please. We're thrilled to have you here with us in this virtual space and to hear from one of my favorite presenters, who I'll be introducing to you shortly. Overdose rates have continued to escalate and are increasing the fastest in Black, Indigenous, and other communities of color, all while having the lowest access to prevention and treatment services. Much of this stemming from the long-lasting systems failures such as the war on drugs. Working in overdose prevention, substance use treatment, and harm reduction roles, and while also working to address racial health inequities, can feel insurmountable and difficult to make changes. Here at the National Overdose Prevention Network, we aim to center health equity throughout all of our programming and have resources such as the Health Equity Tool to aid coalitions or groups in organizing their big picture thinking around health equity. In our Overdose Prevention 101 guide, we have an equity in overdose prevention section with case studies of how overdose prevention coalitions in California have thoughtfully approached health equity in their communities, along with other resources to support addressing health equity in your roles and organizations. Our goal by the end of this webinar is that you'll find new and practical ways to embed equity into your work and spark ongoing commitment to health and racial health equity to create lasting systems change in your communities. Today's event will consist of two parts. The first 60 minutes will consist of the welcome that we just covered, followed with the presentation on committing to equity, a quick Q&A, and followed with case studies. The last 30 minutes is an optional interactive workshop, and we are excited to have a bit more time to dive deep with our presenter on the topic for those that are able to stay on and participate. Moving on to our learning objectives for today, you will all be able to describe current inequities and identify opportunities to build more equitable substance use treatment, overdose prevention, and harm reduction services, and have at least one practical way that you can embed equity in your work going forward. Next slide. Now it is my pleasure to be able to introduce to you our speaker, Charles Hawthorne. Charles Hawthorne is an experienced harm reductionist, facilitator, curriculum designer, and organizational coach focusing on values-driven program design and organizational development. They have provided training and technical assistance to programs serving people who use drugs for the past 7 years at the local, state, and national levels. Charles has worked for a range of harm reduction technical assistance providers supporting internal and external racial equity strategies, implementing harm reduction services, and designing curricula for harm reduction service providers. Charles has created and facilitated education experiences for various communities, including healthcare providers, students, public health workers, treatment providers, harm reductionists, government officials, and the general public. Charles received their BS in biochemistry from Purdue University and their Master of Public Health from Johns Hopkins University as a Bloomberg American Health Initiative Addiction and Overdose Fellow. Welcome, Charles, and I'll hand it over to you now.
Awesome. Thank you so much, Veronica, for kicking us off. I'm super excited to be able to be back chatting with y'all here today and diving a bit more into what it could look like to incorporate equity into your work. So if you want to head to the next slide, please. So the topic of today's talk is committing to equity, how to drive change in overdose prevention, treatment, and harm reduction. And the concept of this workshop is really rooted in the fact that having done equity work at organizations that do harm reduction work work with prevention and treatment organizations, is it can be very, and this is true of DEI work across the spectrum. Um, it's very easy to silo the work of diversity and equity and inclusion into a single person or a single role or a single department. When really what we find is the most successful is when everybody is able to see and align with how incorporating equity into their role allows this work to be much more successful and to actually create the change that we are all really hoping for within our work. And so that's what we're going to be spending our time talking about today. So next slide, please. So the general agenda, we're going to start off with talking a little bit about what does it mean to have access to care, and how does the concept of anti-racism and equity kind of fit into that? Um, we're going to talk a little bit about how do we get there? What is the roadmap to get to anti-racist programs and policies that actually serve our communities in the way that we're hoping to? And then, like Veronica mentioned, we're trying something kind of new today where we're adding on this optional kind of practicum piece at the end of the workshop. So if you only have an hour, we totally understand. If you're able to stay for this extra 30 minutes at the end, what we're able to do is do a little bit more practice and talk about how do we incorporate equity into our roles in a bit more of a practical way. All right, next slide. So some things that I do like to bring forward as conversation agreements. These are kind of my standard ones that I have whenever I do workshops. And this just allows us to make sure that we can stay in generative conversation with each other. Um, and this goes for both this didactic portion and when we move into the practice portion. The first one is take space, make space. So just kind of being conscious of how much room you're taking up within this conversation and understanding that if you're a person who feels really comfortable taking up space, whether that's because of your personality, because of identities you hold in the space, because of your experience level, being conscious that other people might want to take that space up as well. And create room for them by if you notice that you and a few other people are adding a lot of the questions or doing a lot of the talking, stepping back and making some space for other people. And then conversely, if you feel like you're not really seeing your thoughts being reflected in questions people are asking, your perspective coming forward, I encourage you to come forward and take up some of that space and share your thoughts so that we're able to get as many perspectives as possible. Number two, I statements. We can't speak for other people. We can't speak for other groups that we are part of or groups that we are not a part of. We cannot speak for other people who work for our organization or other organizations. We can only speak for ourselves. And conversely, other people cannot speak for us. And so using those I statements, I feel in my experience, that allows us to make sure that we are being clear about these perspectives that we're bringing are rooted in our own experiences and we can't speak for other people's and other people cannot invalidate our own experiences. Um, Third, I like to call this a dukes down space. And what that means, if you've heard that phrase, when you put your dukes up, you're ready to fight. We are not here to fight. We are here to learn. And sometimes when we start talking about things like equity, when we start talking about things like harm reduction, it brings up a lot for us. And a lot of what it brings up for us is defensiveness. It feels like we are fighting other people. It feels like we are fighting each other, that if we do not put our perspective down, other people think bad things of us. That's not what we're here to do today. What we're here to do today is reflect and learn and be challenged. And maybe something's going to poke you a little weird and it's not going to feel great. And that's okay. Breathe through it. We'll get through it together. This is a webinar, not a kidney surgery. We will all be okay at the end of it. So let's just kind of be able to stay focused and when you're feeling that thing coming up that feels like you want to fight, that is your moment for reflection. That is your moment to pause and think, maybe write down the thoughts that you're having in that moment and come back to them and reflect them later. And then along with that, we want this to be a place where we can kind of say it rough, where you don't feel like you have to sugarcoat every single thing in order to get to a point you want to make. We are going to assume best intentions. We are going to assume that everybody is here to learn as best as they can. And that means sometimes the phrases that come out might not be perfectly polished. They might not be ready to go off to press, but they will be ready for us to have a bit of a conversation. And say things as best as you can. Say it a little rough. Feel free to preface it if you're like, I'm not sure if this is the best language. I'm not sure if this is the best way to say it. Um, but say it, because if you're asking it, if you're having that thought, chances are somebody else in the room is as well. And I want y'all and I think that it is important to be able to have that space to say these things, so that, because that a lot of times that might be the thing holding us back from moving forward in this process with this work. All right, next slide. And this is also kind of going back to that Dukes Down piece. This is about establishing a brave space for dialogue. And when we talk about learning, learning is something that exists somewhere between the concept of comfort and conflict. When we are thinking about being in a place where we're really familiar with the thoughts that we're having, we're very familiar with these perspectives. And then there's a place where it's too much. There's too much conflict. It feels like we are too opposed. And what we're trying to really ride the line of in this workshop is that learning edge. And I really like this quote from R.B. Rome, which is, learning necessarily involves not merely risk, but the pain of giving up a former condition in favor of a new way of seeing things, which triggers a lot of things for me, like this concept of grief, this concept of mourning, this concept of having to give up a way that we have seen the world in order to embrace a new way of seeing the world. And I think in times like this, that is feeling more important than ever, that we are able to go through and find comfort and find reflection and energy to engage with this pain of giving up a former way of thinking about things in favor of moving into new ways of seeing things, which, we do a lot when we're young. And as we get older, it gets harder and harder. And this is your opportunity to practice. So let's go ahead and practice. Next slide, please. Okay, so let's go ahead and jump into this equity in substance use treatment. I'm really excited about this topic. This is actually something I was working on my master's thesis on. This is next few slides are kind of based on the work that I did for that project. And it really is something that's super helpful. So next slide, please. And so one of these questions that I do like to bring forward a lot is, what does true access to care look like? We spend a lot of time as public health professionals, public health students, healthcare workers, talking about people having access to care or not having access to care. And there's a lot that we can say about what access to care means. What I have found as one of a really solid model of doing that was actually created by a author, J.F. Levesque, in a paper that they wrote. And if you hit the next slide, please, this is kind of the core definition that he used to define accessibility in healthcare. And he defined it as the opportunity to identify healthcare needs, to seek healthcare services, to reach, to obtain or use healthcare services, and to actually need the services that are fulfilled. So I really like this quote because I feel like so much of the time when we are working within public health, it feels like we are facing an impossible job. There is, we're like trying to pick up the smoothest slippery orb and move it somewhere, and there's nothing to grip, there's nothing to grab. And what I like about this quote is we have so many opportunities to improve these different ways of accessibility to help people access care. So this is something to kind of think about when we're talking about accessibility in healthcare. How are we making sure that the people who we want coming into our care are able to identify the needs that they have, that they know where to look, that they know how to get there, and that they're able to get there, whether that's physically, whether that is through it feeling welcoming or not, and them able to actually reach the front desk and feel comfortable at that front desk or feel comfortable at the care, to be able to use or obtain those healthcare services, which comes down to things like accessibility, physical accessibility of the space, financial accessibility of the space. Does it make sense for them, and does it match up with what their needs are? And then when they're getting there, are the needs that they are getting, are the services that are being fulfilled actually the thing that they need? And this is the biggest thing that comes up a lot of times in treatment settings. And I'm sure that there's people on this call who are people who either are current or former people who have accessed substance use treatment services and have spent a lot of time arguing with providers that the thing that they are being told they need is the thing that they need when they are actively saying the thing they need is something else. They have a doctor telling them, well, you need to go on this medication. You need to stop doing this. And what they're saying, and what your response might be is, I actually need housing. I actually need a job. I actually need mental health support. And that's not something you're able or interested to provide. Um, and so that is like something to really hold on to when we start moving into talking about equity, because equity, when we approach it from this place, it's not about being all fuzzy and cute. It's not about kindergarten, we all want to play together. It's about these are real people we are talking about. These are not mythical friends that are going to come and share our space. These are real people who are being limited in their access to life-saving care and life-saving support because the systems we have are not just not designed to serve them, but are actively designed to keep them out. And that means it doesn't matter how welcoming and open you are. It doesn't matter how excited you are to see them at a certain point. Sometimes that's really nice, but there's more to that. It doesn't matter your own personal view on it. What we're talking about a lot of these times are these systems, and these systems needing to be aligned along all these different areas to make sure that as many people as possible are able to access our care. So I know people are always expecting people to whip out stats. So the next few slides, I'm going to whip out some stats because sometimes that's what our brains need in order to really lock in around this stuff. So next slide, please. So the first thing we can kind of talk about are these overdose death rates by race and ethnicity. This is the most accurate, current, up-to-date data from 2021. And these are accrued rates per 100,000 residents. This is some data from CDPH. And what we're kind of seeing is across the board, most overdose deaths are being caused, are showing up disproportionately in Native American and Black communities across California. Especially for this all drugs category, especially for opioids, including fentanyl, especially for stimulants, and even for all psychostimulants, and even for cocaine, which would include both cocaine and crack. Black people have a much higher overdose death rate than all other groups. So when we're talking about actually serving community and serving people based on need, this is a thing that we're focusing on, of saying most of the people who are being harmed by this are people who have the least, who are having more limited access to the care services we're trying to provide. And if what we're talking about is building systems that serve these people, then that means that we need to be focusing on these communities when we're building our systems. Next slide, please. And then when we're talking about it by age, what we're seeing is that it's especially when we're thinking about as people get older, we're seeing much more a wider birth of folks from that white race group, white ethnicity group. But especially for young folks, for college age children, and up to even up to age like 54, there is a lot coming from this Latino group. So even within that category, when we're even breaking it down just by raw numbers, most of the people who are navigating substance use disorder are from this Latino group, which is a large percentage of Californians. And so there's a whole other section that we're kind of coming to mind of thinking about, even just based on raw numbers, not prorated by relative data. There's a whole other way that we can look at this, and it still is coming out that there are racial groups that are non-white are the people who are facing the brunt of harm from substance use disorder. Next slide, please. And then we look at our data from the hub and spoke data. So this is from the DHCS hub and spoke SOR2 reporting. So for people who are familiar with that, you know exactly what that means. For people who are less familiar with that, this is some grant funding that came down in order to improve access to substance use treatment services at varying programs throughout the state of California, with some funding from federal government. And what we are seeing in this is that out of all of new MAT, new medication-assisted treatment patients that were served under this grant, over 59%, almost 60% of those new patients were white, which means that we're not necessarily bringing in lots of new not necessarily bringing in lots of new patients that are of these varying groups, of these varying racial groups. And so it's just something to really pay attention to as we're moving through this is most of the people who are coming into this new program, into new substance use treatment programs through DHCS SOR2 at least, are not people of color. And then next slide, please. And then this is some data from California Bridge, which is essentially breaking down all of the zip codes in California based on their racial and ethnic distribution. And so it essentially splits all these zip codes into two categories of being mostly people of color, or actually it's split into five categories of being 0 to 20% people of color, to 20 to 40%, 40 to 60%, 60 to 80, and then 80 to 100. And what we're seeing across California is, and this graph is based on the number of buprenorphine prescriptions per 1,000 residents. So what we're seeing is in these zip codes that have mostly white demographic, there are almost 10 times as many buprenorphine prescriptions per 1,000 people, as opposed to the zip codes that are 80 to 100% people of color. And so what we're seeing is as the proportion of people of color increases in a certain area, the access to buprenorphine and the prescriptions of buprenorphine are going down. And one of the hard parts of this data is that one of the hard parts of this data is all of this data is kind of proxy data. We don't necessarily have like direct one-to-one because, you know, collecting data around substance use and treatment and things like this is very, very challenging. But what this data is showing, and there's lots of questions within it, which is like things that come up a lot when we start talking about equity in MAT. Do people of color, do Black people, do Latinx people, do Native American people want to use buprenorphine? Is that something that they're interested in? How are we having conversations about it? All these are really valid questions. But when we are operating from a place that we understand that buprenorphine is a gold standard of treatment for especially opioid-related substance use disorder, and we're seeing that a lot of the deaths that are occurring from opioids are disproportionately impacting people of color, there's some concerns that come up around not necessarily having equal access to those based on this data of seeing that based on these zip codes, there's a big range in the ability of people to access buprenorphine. And this is actually also building on some data that I don't have included in here, but is by a researcher named Helena Hansen, who has done a lot of research around buprenorphine and methadone and seeing that there are much fewer buprenorphine prescribers in areas that have more people of color and more methadone clinics. And in white areas, there being fewer methadone clinics and much more buprenorphine prescribers. If you kind of know more about the difference in how people experience buprenorphine and methadone being a medication that you need to go to a clinic usually every single day in order to get a prescription. The timing of it is super challenging. It's very, very heavily regulated. as opposed, and then buprenorphine being a pill that you can get a prescription for. You can walk out, you can have 30-day supply right off the bat. It's much easier to fit into your day-to-day life. It definitely brings up some stark differences in experience that patients are having on the medication. Okay, next slide. So moving into talking more about racial equity, um, when we start thinking about all of this data and bringing it into this concept of talking about racial equity, um, there's this piece that comes from the Aspen Institute, and a quote from them is saying, in a racially equitable society, the distribution of society's benefits and burdens would not be skewed by race. This would be a reality in which a person is no more or less likely to experience society's benefits or burdens just because of the color of their skin. And so when we are thinking about all of the ways that racial discrimination compounds within this country, dating, and this is like one of those things that we could have a 10-week webinar all day about and still just be scratching the surface. But it's everything from access to care, access to financial liberation, locations of services, abilities to live in certain areas, treatment how you are treated as a person when you enter some of these places. All of that ties into this. But the washout of it is the data that we just saw, where we are seeing people of color be disproportionately burdened by a system based on being their experience as people of color and the historical experience of being people of color over the past 400, 500 years in this country. All right, next slide. So when we start thinking about bringing racial equity into our substance use treatment landscape, there's a few things that we kind of have to understand, and there's a few things that we really need to move forward with when we begin to talk about it. So first, the thing that we really have to understand is our world is steeped in racism. It doesn't matter how good we feel about it, about other people. It doesn't matter our own thoughts, our own experiences, our own families, our partners, our children, what matters is understanding that when we start talking about racial equity, we're not talking about you, we're talking about a system. And so when we have to understand, when we approach it that way, what we begin to see is how we need to shift our systems in order to better accommodate as many people as possible. And then along with that, we've been socialized to just not talk about social injustice. And I know it's something that comes up for me a lot of the times. I know it's something that comes up for people who I talk with a lot of times, where it's really uncomfortable. It's not fun. It's not enjoyable. And it's especially not enjoyable because sometimes we feel like it's reflecting about us. We feel like it's reflecting about our own perspectives, when really what we're naming is that these things are real, and these experiences that people have are real and are baked into the fabric of our country, of our medical care system, of our prison system, of our everything. And complex emotions come up because of that. Maybe you're feeling guilt right now. Maybe you're like, oh, okay, like I'm a person who used drugs, who's white, and it was really easy for me to access treatment. And I wasn't really thinking about how it was hard for other people, and I feel bad, and I don't really know how to navigate that. And that's okay. You're allowed to have those feelings. Something that I learned a long time ago, I did my training around harm reduction at HIPS, which is a program in Washington, D.C., that primarily serves trans women of color who are doing street-based sex work, and also had a syringe access program and an overdose prevention program. And something that came up a lot in our training was this concept of shame and guilt, and feeling bad about who we are, feeling bad about how other people are treated. And something that I was kind of told repeatedly is that's a stopping emotion. When you start feeling that guilt, that shame, that's something that's centering you. It's centering your experience, and it's stopping you from showing up in empathy and showing up in understanding for the person who is actually navigating the harm of the situation. So being able to release these feelings of guilt and shame, being able to process through these feelings of anger, resentment, defensiveness, and denial is how we begin to open the gateway of beginning to do this racial equity work. And then along with that, understanding that dismantling racism is everybody's work. It is not, and this was something I would say a lot when I've held equity roles before for organizations is my job title might have equity in it, but I'm gonna be damned if I'm the only one doing equity work at this organization because I will spin my wheels forever. I'm not in charge of the financial systems. I can't make us have a more financially equitable system. I am not in charge of hiring. I can't make our hiring processes more equitable. I'm not in charge of the programs we're creating or our development strategy or any of that. So, what I can do is hold a process. I can hold the people who are having to figure that out and support them with that. But really, if what we're trying to do is dismantle racism within our work, whether that is at our organization, whether that's within our family or our friend groups, whether that is in other structures that we're working within, there's an understanding that we have to lean into that this is going to be everyone's work. And the minute that you begin saying or approaching it like it's just that person's job, you are now the barrier from it moving forward. And understanding that the problem and the solution, therefore, is in policies, not people. And I feel like I've spent a lot of time, and one of the biggest lessons I've learned, especially starting out as a young person, I think that I'm going through a bit of a renaissance right now. I think a lot of people are. It's one of those things that you never think is going to happen to you. You think you're 22 and you just know everything about equity and social justice in the world, and all these old people just don't know what they're talking about. And then you grow up a little and you're like, okay, this is a bit more complex than maybe I was allowing myself to see it as at the tender age of 23. And something that was a big flip for me was beginning to see that firing that person isn't going to make this organization less racist. Maybe there's a person who's annoying, maybe there's a person who's perpetuating it, but the biggest lesson that I've learned is the systems that we build should allow us to say that no matter that you could have the most racist, most unhinged person who is there to cause harm, specifically to racial groups or gender groups or whoever, and we should be building systems that do not allow them to do that. The way our systems should be built should be that nobody should be able to pass or create inequitable policies or practices. No matter how their personal feelings are. That's the way that we should be building our policies. And so, not focusing on individual people when we're having these conversations and what they need to be doing different, but we can focus on what, as individuals, we need to be doing different. And we can focus on the structure and the programs and the policies that create space for people to be different. And to kind of close this out, it's pretty clear to say that health professionals have not really been taught about these connections that come up between injustice and oppression in health. And I spend a lot of time, especially with young doctors, with young nurses, and I think it's something that as people kind of are seasoned in the field, they see much more clearly, even if sometimes they might be calloused in other ways. Um, but there's not a lot of teaching that goes into training about like how racial injustice, gender injustice show up in healthcare. And so understanding that if this feels new or this feels challenging, um, that makes sense. There is not really a pathway for people to be taught this usually. And so leading into that and understanding that there's a lot of learning to be done. All right, next slide. So when we talk about anti-racism is when we're really talking about a system in which the policies, practices, and procedures to promote racial equity. So when we think about racial equity is the concept, it's the idea, it's the feeling we're trying to hit. Anti-racism is the verb, it's the how-to, it's the what are we doing. And I think sometimes anti-racism, it feels like a really big, heavy word for people. And I think it should, because it's a serious practice. It is thinking about how are we actively pushing against the systems that are being created to improve them. And that does not always feel comfortable. It usually does not feel comfortable. And there's something to say about the things that we are willing to do that are uncomfortable and the things that we are not willing to do. And that is your own personal journey that I cannot speak to. But what I do know is that if we are leaning towards and we're naming the goals that we have for our system to be racial equity, the practices that we need to be bringing in need to be anti-racism. And so when we speak on anti-racism, it's about generating anti-racist ideas that uplift the innate humanity and individuality of BIPOC people, Black, Indigenous, and people of color. And so when we're really naming this practice, it's really thinking about how are we seeing people as individuals who need individualized support, not just lumping this in and saying we need to throw a Black person on our marketing campaign because that's going to make Black people want to come. It's about saying, what are the actual needs that people are bringing forward? What are the things that people are naming that are making them feel less of that access to care? So going back to those points we named, that ability to identify their needs, to seek healthcare services, to reach those healthcare services, and use them. And then for the services they're getting to be the needs that they actually want met. How are we actually thinking of these category, this what we even here are boiling down to a large category, thinking of the people within these categories as innate individual humans that have their own needs that we need to kind of be thinking about and considering. And where that puts us as people is it forces us to really analyze the role of systems and institutions in the racial inequities we see, rather than just like blaming people and pointing fingers and saying, she's really mean at the front desk, and that's why no Black people want to come in here. That's not a structure. That, you could bring somebody else in and they could have a bad day and you could be in the same situation. So how are you building out your system in order to really think about what are the institutions and the systems that are really causing these inequities? So let me go ahead and hit the next slide. So what we're going to kind of be focusing on as we move through the rest of this workshop, and what I'll kind of leave y'all with as a floating question, especially for maybe the people who won't be staying on for our practicum piece, is thinking about how do you see anti-racism fitting into the goal of advancing care for people who use drugs? And I think for me, the places that it often really lands is coming back to that sense of access to care. How are we incorporating anti-racist questions and thought processes? How are we thinking into helping people access healthcare, helping them be able to see themselves coming to your care, helping them feel comfortable accessing it, helping them actually get it and for what they're getting to be the thing that they need. And really bringing in that practice of naming the systems. And it's really easy to blame people. The easy thing to do is to blame a person and to say, you did this, you did that. That's the problem. It's harder to say, we are all existing in this system. And by continuing to work here and not say anything about it, we are perpetuating this system. And the only way to actually make shifts in this system is by naming it and having conversations about it and making intentional decisions on how to improve it. So one thing that we can kind of go into to name a little bit more of this is some of these case studies. So if you want to hit the next slide, we'll talk a little bit about a few case studies that we can kind of bring in here. And I'm going to kind of bring Veronica back to just chat a little bit through these. I feel like I've been talking a lot. Do you want to read the case studies? If you want to hit the next slide, Jeff.
Yeah, I can read those for you. So, case study A, Sunshine Treatment Center is an outpatient substance use treatment center in the Central Valley of California. While over 30% of the community in their area identifies as Latina, less than 2% of Sunshine's client base are Latina. When this was brought up during a call with a funder, one of the directors of the Sunshine expressed that they believe that Latina people are less interested in accessing medication for substance use treatment.
Okay. So let's break this down a little bit. And when we're really naming this, what we're thinking about, and maybe for folks who are maybe a little bit more around the country, the Central Valley is an area that does have a really large Latinx population. Um, and there's a lot of disparity that comes up in access to all types of care, not just substance use treatment, but all types of care based on race in those areas. And this case study is based on a real experience that I had of people naming that they just think that people of color in general are just less interested in getting this care, and that's why they're there. They're not coming. Um, so Veronica, what's kind of coming up for you when you like read this case study for the first time?
Oh, for me, I first think of is are the services being advertised? Are they only in English? Are they in Spanish or any other languages that the population in that part of the Central Valley can actually read and understand?
Yeah, I think language is a huge piece of that. So, one thing to start thinking about is when you're really assessing your community and when you're thinking about when you're looking at your area. And for everybody, this is going to be kind of different. Maybe you are in an area that has a much higher proportion of Southeast Asian populations, maybe a much higher portion of Black population, maybe a higher proportion of East Asians or whoever might be there. Thinking about who is in your area and what would they need to be able to access this. And step one is, can they read the advertisement? Can they see who's coming in? Can they see themselves coming in and know that they're going to be supported? Is there somebody at your clinic who speaks some of the common languages around this area? And it's something that is a very American concept of it being odd that we don't really have a national language, but we have kind of this de facto national language, and the fact that we don't oftentimes offer services in other languages, even when we understand that there's people in those areas. And we expect those people to not only come in and communicate all of their health needs, maybe in a language that they are way less familiar with, but also just not even meet them halfway around that. So language is a huge piece. I think that there's even something for me that comes up in the expression of this thought, though, and the comfortability in the expression of this thought, which is what does it mean when you are directing a center that is supposed to be serving your area and you're just like, they're just not interested. They don't care. And there's no thought process of, okay, what make them interested? Is this because they don't need this service? Are there just very, very few Latinx people who are using drugs or who are interested in shifting their drug use? Do they not see buprenorphine as something that, or medication assist treatment or the treatment system as one that could serve them? Is there a way of kind of building this that allows people to see themselves more? And I think the thought of this that comes up a lot is seeing how successful other groups that do community specific substance use treatment are able to this, where there are substance use treatment clinics in Central Valley that serve Latinx populations that have huge numbers of Latinx people coming through their doors, seeking treatment. Too many, actually, sometimes for them to be able to serve all of them. So it's not about interest always. Sometimes it's about comfortability and being able to actually meet people where they're at and serve them. And when you have people in leadership who are expressing views or who are naming views around just being less interested or people just don't want this, and that's not a red flag to them, um, that's something to really talk about because that is where the rubber meets the road. And that's where we really start talking about what is the system? How are we designing a way that is intentionally built to connect the population in our area and the population who we were serving and comparing those numbers in order to see, are we actually connecting with this general population, with our whole population in a way that is meaningful? And maybe you do all this work and you get a few more people coming in and maybe in the long run, like, yeah, like the people maybe prefer to go somewhere else. They're interested in something else. And maybe and what I see more often is people do this work and they end up getting huge swaths of new people coming in that access care in their space because there was just people who were waiting and looking for services that would be able to serve them in the way that they needed to be served. All right. And then case study B. You want to read this one too, Veronica?
Yeah, you got it. Moonlight SSP is, or syringe service provider, just for folks who may not know what that stands for, is working with a tribal health center in the Midwest. They have been running into challenges working with providers at the center as they have been trying to incorporate syringe services and naloxone distribution into service delivery. Providers at the center noted there's a lack of trust of external health organizations due to both historical trauma and recent exploitation by researchers and direct service organizations.
Yeah. So let's kind of do the same thing around this one. So we have this SSP that's trying to come in, and this is a tale, this is a story that has come up time and time again across the country. Um, so naming that they're trying to come in, and there's this program that wants to support this tribal health center with bringing syringe services and harm reduction care into the way that this service provider is working with this tribal community. And at the center, they're just saying, we don't trust y'all. Well, there's a lot of people coming in who want to exploit us, who want to do all this research, and we are not left better because of them. Or they want to come and do things their way and not necessarily our way. And then on top of that, there is a whole swath of historical trauma that comes up for people when you have people external to the community coming in and offering help, and that help not being delivered in a way that is conscious or built around that community and their interests and their needs. Um, so yeah, do you have any thoughts on this, Veronica? Does anything kind of come up when you look at this?
For me, the first piece that really stands out is that lack of trust. So if I'm either the external organization, how would I go about building trust with the tribal health center? Like what would those steps look like?
Mhm.
And what do you think?
Yeah. I think that that sounds great. And I think that there's something that really comes down to when we're talking about doing cultural work, that trust is a huge piece of that. And I think people are really uncomfortable. I think a lot of white service providers, especially, are very uncomfortable with the idea that they are not trusted. And I think that that's a few levels of work. I think that there it hits somewhere in the ego because you're like, I got these degrees, I did all this work, I learned all these things, I'm doing it. Why don't you trust me? And there's also a place of what does it mean for you to feel, which I feel like is something that comes up a lot in contexts like this, where people feel like they're doing charity work, where they're coming in, they're like, we're coming here to save your community and do all these things for you. And you should just be grateful for the fact that we're doing it. And when people on the other side pump the brakes and say, hey, this doesn't feel great to us, I think that that hits someone somewhere in a weird place. And I think it's one of those similar things that come up so much around the concept of people should be grateful or should be this or should be that, that I've seen time and time again come up in homeless service care, that I've seen time and time come up in substance use treatment care, of the fact that I would even talk to you and even offer you help should have you bent over backwards to say yes. um, when that is directly against that concept that we think about in anti-racism of recognizing people's innate humanity, that people might not be interested in receiving care in the way that you're speaking to, that people have individual thoughts and experiences that put them in a place where they want to be able to uh make decisions and choices and have autonomy about the things that they engage with. And when I read this case study, one thing I think a lot about is some work that I did years ago with a Native American health center in San Francisco, and doing some harm reduction training for them. Um, that ended up just being one of the most rewarding workshops that I ever did, and just being able to talk about like hearing from them, like what are the practices that you bring forward to your communities when they're navigating substance use disorder. And there's like a whole swath of things that people talked about. Everything from cultural practices around sweat lodges and medicine and plant-based medicines and really culturally like not cultural knowledge around plant-based medicine. People talking about showing up and getting support from elders in the community from just wrapping their hands around people and supporting them and showing up for them in ways that are like very different from the Western version of thinking about substance use treatment, which sometimes can feel really individualistic. And thinking about this is less about saying what you're doing is wrong and the way we are proposing it is right. It is more about how are we supporting you with building out as many tools as possible to be able to support your people. And if something doesn't feel good or doesn't make sense for you, that's okay. And we can come back to it. And it's not about me just coming in and chop shop, bam, 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 here's your work, here's your entire guide of how to do harm reduction. Goodbye, I'm leaving now. It's about how are we actually building a relationship that is much more long lasting. That is about you can call me and we can talk about this. It's not just about I'm going to do this and go because this is my charity work or my job, but it's about this is about serving my community and you are a part of my community too. Um, which I think comes back all a ton to just like the concept of othering, of what does it mean to talk. I think it's something that I see so much in substance use treatment and public health work, where the concept of us or the concept of we versus the concept of y'all and them, of saying like when are you speaking to people and referring to them as I, of we or us? Are we people who use drugs? Are we people who are serving our community? Or am I a person serving my community and you're serving communities in your community that I serve? Or y'all are over there doing y'all thing and I'm over here just coming in doing this thing for you. Um, which I feel like does not land well for communities, and especially does not land well for communities of color who are a lot of the times explicitly separating themselves from larger communities, especially white communities in their area, because of a lot of times this historical trauma and exploitation.
I wanted to uplift here really quickly, Charles. One of our audience members, Tony, had brought up that you shouldn't be building connection or trust in a rushed manner or with a timeline in mind, and that you really need to be asking what's valuable to the community you seek to support. So I think that's something that you had brought up as well, of like, this isn't going to be something that you're just going to check off on a box, but it's going to be something that's going to be a slow process to be able to build community with one another and building those partnerships and really trying to repair that distrust and those recent exploitation and trauma that had taken place.
Exactly. And I can hear people on the other side of their computer, even though that you are muted, just thinking here and being like, but the grant says we need to have it done in 12 months. Um, and that is kind of the problem that we are continually facing. And do I have an answer to that? Not necessarily. But there is something to say about as we are building out this work and building out our grants and figuring out how we fund these things and make them happen, because we do exist in capitalism and we do need to eat. I need to eat. Y'all need to eat. We need to pay for our housing. We need to do these things. One day, I hope we live in a world where none of that is true. And until then, it's a reality. And so one thing to think about is if you are, and this is where we really start thinking about how racial equity begins to get incorporated into all of these roles, is thinking about how are you talking to your grant writers and your grantors about how, and if you are a funder, how are you talking to your grantees about slowing down? How are you talking to them about intentional relationship building and not being rushed? How are you rethinking deliverables in order to create space for what could be a process of trust building that doesn't feel like you have your back against the wall? And that's really how we make the difference between feeling like we're just coming in, rushing, trying to finish a job versus taking the intentional time to build a relationship um, with people who are in our community who we want to have profound love and respect for and show up to support in a way that is meaningful in the long term and not just chop, we're done. Next. Because people see that. As much as you might think people don't see that, people see that every single time. Okay, well, let's go ahead and pause real quick and switch over to this Q&A portion.
Yeah, I think we only have a couple minutes, but I think that there was one question that really stood out to me that I think we should touch on, which is what advice do you have for those working in states, or this could be just in positions that have DI implementation mentioning limited in their work? So what would you do, or what advice would you give to them if it's mentioned as a limited portion of their work when we're trying to figure out how to embed it through all pieces of a role?
Well, I would recommend that you stay for our practicum portion because we will be talking about that. And I think the high level thing that I would offer is it's less about thinking about equity work as something separate from your job and more thinking about how do I practice equity in everything that I am already doing. And we'll talk about a few ways that that might look. And it comes all the way down from thinking about equity in the way that we write our grants to thinking about equity in the way that we order food for dinner. How are we when we're ordering lunch for our work meetings? Are we looking at local restaurants? Are we looking at restaurants ran by people of color? When we're working with building out our programs and policies, are we pausing and running through scenarios that allow us to consider all the different people who might be accessing our services? Are we building out our communications plan and taking a step back and looking at it and asking ourselves the questions, is the people who we want coming through our doors reflected throughout this communication plan? How are we showing up for that? Those are the questions that are really helpful. So this is a little roadmap. It's a little thing that I drew up because sometimes it's helpful to have a visual. And this is a practice that, and I would really recommend if you were to write down some steps or some perspectives, especially if you're in a place of thinking about your next thinking about your future work plans, thinking about work you're trying to gear up at your organization, thinking about maybe proposing something to leadership at your organization, or if you are a leader and you're just looking for some support with how to kind of organize your thoughts about what needs to get done. I think that this is a really helpful process. And I'll kind of walk through each of these little stages and offer some questions and tools to kind of support you at different places. And what this kind of involves is starting with doing an equity audit of reflecting a little bit on some of your practices and policies, strengths and weaknesses, moving into building space and capacity to talk more about it, doing some individual education, and then creating a work plan to move forward. So this first portion that comes forward is this equity audit. And the purpose of this equity audit is to force you to slow down. It is to take a beat and say like, hey, what do we actually need to do? How do we actually need to get there? Instead of just kind of start throwing spaghetti at the wall, I see that happen so much. People get usually the thing that kicks off a lot of these conversations coming up around equity um, is anger and frustration. I just actually had a reflective moment this morning of an organization that I worked for, and there being a lot of anger. That was the thing that moved us forward into our equity work, which is really hard to hold. It's really hard to maintain the energy. It's really hard to drive it to a point. And so being able to lean into this equity audit sometimes is about taking all these thoughts and perspectives that people are seeing and organizing them into a way that fits more with the system that we're operating within. So this could be something that we call like a SWOT analysis or something like that. Um, or what is it, TOES, where you do it backwards, the same difference. And what that can often look like is just helping identify some of those strengths and weaknesses. So some key questions that come up for me when I'm doing these types of analyses are, who is accessing our services? How does that compare to the population in our area? Does that make sense? If somebody were to show you these numbers side by side, would you be like, okay, cool? Or would you be like, that doesn't really seem right? How are people who are not accessing our services different than those who are? Sometimes this is a little bit more work. One of the things that we were able to do when I worked at National Harm Reduction Coalition is we actually ran a statewide analysis of people who use drugs, where we did this massive survey portion where we interviewed a ton of people who were accessing harm reduction services, and then some other people who also were not accessing harm reduction services either at all or regularly. and thinking about those people's experiences. And some of the experiences that came up were the people who were not accessing our services did not have reliable transportation. There was not a bus line that went from their area to by the service provider. Um, they had had negative experiences with this service provider before. They didn't feel like the services were designed to serve them. Those are the questions that are going to kind of help give you the roadmap moving forward, the answers that'll help give you the roadmap moving forward of what you actually need to work on. If you're over here thinking like, oh, we don't have enough people of color in our advertising, whole time people are like, I have no idea how I'd get there if I wanted to. It's a much different thing to be navigating and a much different conversation to be having. And I love this last question. What do people say and think about our services and programs? The streets talk. The streets talk. Anybody here who has like done any sort of like street-based services, who has done any sort of community work, know that people talk about y'all. If you are a direct service provider, your name is in the streets. Like people are like having conversations. And those oftentimes are some of the most enlightening thing about their services. And I'm not even saying that that's just bad. A lot of times it's also quite good. Sometimes it's people saying like, oh, if you need to get this done, go see Monica at this spot. She's really quick. She's going to handle it. She got all the people's numbers on speed dial. She'll call them. She'll get you done. If you go to this person, they're going to take a week, but they are all right too. If you go to this person, it's just not going to get done. They don't even think about it. They don't care, whatever, which can sometimes feel hurtful, but is also really supportive in figuring out what's going on. And then some tools that are going to be helpful during this place is data collection. And this is also where you start moving into this tool called results-based accountability, which I believe will share a whole list of resources maybe closer to the end, or if you have that here, maybe you could kind of drop it into the chat. But results-based accountability is a tool that kind of brings together these concepts of data collection and maintenance with actually digging us into being held accountable to something. And results-based accountability is saying, we're not judging you based on what you did, we're judging you based on what you got done. We're judging ourselves based on the actual results that come out. Maybe we did a ton of work, but if our actual data didn't move, then it wasn't the right work. And we need to be doing some different work, or we have to do that work in a different way. I'm loving this comment from Roger on here. Saying it's so true. I'm known in the unhoused community as the Matt connection. That's such a proud thing to be able to name, is like, oh yeah, I'm the person who people come to for this care. Like that's awesome. Thank you for sharing that. And then Veronica just shared in the chat this results-based accountability piece. So let me make sure I'm not dragging too much. Okay, I'm okay. Veronica, so when you look at this equity audit thing and you think about supporting other organizations with beginning to do this work, what are some of the responses that come up for people, do you think, when they start talking about collecting some of this data or some of these learnings around what they're doing and how they're showing up in community?
Yeah, I think with some of the coalitions we've worked with here in California, once they start digging in and doing more of this like equity audit and asking themselves these questions, they have even more questions. And they're like, well, what do we do with this information? Like, how do you start bridging these gaps that we're figuring out? And I think one example that I really appreciated was El Dorado. They they found out that their Latino population was not accessing services, but it was because of those things that we brought up in case study A. They didn't have trust with the providers, they didn't have access to the language services, and they just didn't even know how to get into medication assisted treatment. And they ended up creating an advisory body with different community organizations and also members of the Latina population in their community that were trusted individuals to be able to tell them and give them information and have those real data numbers to take accountability that they haven't been providing these services for that population, but then to be able to start building that trust and be able to empower that part of their community to help influence the services that would benefit them the best. And I think that was something that was just really, really amazing to see. But I feel like that's that piece, that bridge where people get lost in of like, I have more questions now that I started
Yeah.
doing this work.
Yes. It's one of those things of I really appreciate you sharing that story, and I totally agree. And there's a few things that I want to pull out in that. I think that having more questions is one piece of it. It's like it's once you start pulling that thread, it's like, oh, it's a lot longer than I thought it was. And now it feels like you have a whole other job to do. And sometimes you do, which is hard. And sometimes that's that thing of like, the thing that my parents would always say is there are no shortcuts, period. You will always end up doing the work at some point. It'll always come back. And you can do it now. You can do it 5 years from now. You could have done it 5 years ago. Um, but now is what you got control over. And I think the other piece that I really appreciated was the taking accountability of naming it, of saying like, oh yeah, this was a way that we weren't showing up and we want to show up differently. I think it can be kind of like, I don't love this language, but it can be kind of crazy making if you ever had like a friend who's maybe showed up in a way that was really poor and then one day they just showed up different and there's no conversation about that, it can feel like, what's going on here? As opposed to when somebody's like, hey, I did this in a way I didn't like and I want it to be different. The way that that can really soothe us and build that bridge for us to be able to come back is much different. And that's something that happens within communities all the time.
Yes.
Um, and so that's something that we really that is huge for that. And then there's this question in the group chat. What type of QI models do you recommend to get a raw evaluation of what your organization needs to do better? I think that a mix of just a SWOT, I don't think it needs to be necessarily super complicated. Like I do think a mix of like starting with this SWOT analysis, like a strengths, weaknesses, opportunities, and threats, along with like results-based accountability tends to really do the job. You do not want to overcomplicate something like this because that is how things get lost and like it gets harder to maintain. And so I think that those are really solid places to start. And there's another resource that we will share maybe now or maybe later. Veronica's quick
I
enough
can share it now.
around the course. So there's a course that I worked with some great friends of mine over at Partners in the Works and Reframe Health and Justice. That is on this exact topic, racial equity in substance use treatment care. And there's a lot of work that we put into that of thinking about how do you kind of build these actionable topics around this. And this is a team of people that work who have been executive directors, who have been done quality improvement work at large harm reduction and substance use treatment organizations. Um, we all really were able to pour a lot into this course, and it's free. It is a free course. It was something that we did with the support, I believe Vital Strategies funded it, and it was something that we were able to do with their support to make it free for everyone. So definitely take some time to look through this, send it to leaders at your organization, take it as a group. I love doing that type of stuff. Do an e-course in your staff meeting, 30 minutes a day. It's like, a quick ab workout or something. Just that's how you build your strength up. All right, next slide. I'll be moving faster after this. So once you kind of do this equity audit, now you have all these questions, and that means you need some space to work on it. And so thinking about how do we create capacity to move forward is huge. Who are the people? And so some of the questions that I recommend moving forward are, who is the person tasked with advancing equity work? Maybe the answer is nobody. Maybe the answer is there's one person. And how are they empowered to complete this work? Um, I find that a lot of the times it is either one person whose job is to do equity, or it is one person of color who is taking on the work, whether paid as part of their job or not paid at all, who's just kind of doing it. And the most important place is how are they empowered to complete this work? If you are not in charge of people in whatever structure we're naming, you can't actually make them do anything. And so there's a lot to kind of bring forward about what does it mean to ask somebody to do systems change without the ability to change systems, which on one end is deeply ineffective, and on the other end is a recipe for burnout. And it's something that I am really cautious of, and I warn a lot of young people of color who work in this field against, which is don't get caught up spinning your wheels on projects that you actually have no power over. because you are just going to hold all the frustration and none of the ability to actually alchemize it into change. And so one of the ways that you can help show up differently is by creating the space for that change to happen, by giving that person power, creating space, or just empowering them by saying, you give me an idea, we're going to make it work. And so being an equity manager or a director can manage the projects that are going on, but everybody should be having a hand in completing the work. And this includes both leadership and support staff, not just direct service staff. And this is something I also see is this blame that often that gets put on direct service staff of saying, y'all need to be doing your job differently, when really a lot of times it is a lot of the people who are building and supporting the structure as well, who all need to be built into it in order to make it better. So the minute, and this is something that goes for equity work, it goes for healthcare work, and it goes for relationships of all sorts. The minute you start saying this is what you need to do, and you're not talking about what, as an individual, I need to do, you are already messing up. That's some free relationship advice. My anniversary is this weekend. So that is the thought that's coming out. Thinking about the minute that you start telling people what they need to be doing differently, you are already losing. Focus on what you can do differently and focus on how you can support other people in doing the things that they do want to do or what they can do. And then these last pieces about thinking about how frontline workers offer services, but leadership and back offices build them. We have to create room for multi-directional feedback. Everybody has expertise, including our patients, including our leadership, including our frontline staff. And this work can be complex and challenging, but the wins are worth it. And I encourage you to really lean into that.
And I just want to thank you for opening up this conversation for folks to be able to join in on today. Here we have Charles' information if you'd like to reach out. Hopefully your inbox doesn't get too crazy, Charles. But just really want to thank everyone that's been able to be on this call. Thank you for sharing. I know some of these moments can be really, really personal, even just in the reflection of maybe missteps that you've had in the past. But like Charles had said earlier, we can only look to the future and how do we make steps and incorporate some of these practices that were shared today. And so thank you so much. I believe we had the survey link go out, but we'll put it in one last time. If you're not connected with us already, please put your contact information to nopen.org/contact so that way we can have more events like this in the future. And the survey link, we'd really like to hear your feedback on having this more interactive piece with our larger national audience. Let us know what we did and what you'd like to see in the future. We look at all of these to be able to build all of our events. And thank you again, Charles, and thank you to everyone who made this possible today, which are you, our attendees. Thank you so much to being open to learning and having this conversation.